All right. Hello, everyone, and welcome to today's Quality Measures Behind the Curtain webinar. This webinar series is coordinated by the Aging Initiative, which is an NIA-funded initiative that bridges the expertise and the leadership of two powerhouses for research on multiple chronic conditions. The two powerhouses are the Healthcare Systems Research Network and the Claude D. Older Americans Independent Centers, or PEPPER Centers. The Aging Initiative is led by Dr. Jerry Gerwitz at UMass Chan Medical School, along with PIs, Elise Adams and Jay Magaziner. My name is Heather Whitson, and I'm a professor of medicine and the director of the Duke University Aging Center, and I'm part of the Aging Initiative Dissemination Workgroup, which is co-led by Dr. Leah Hanson at HealthPartners. Due to the number of registrants on today's webinar, we've placed the phone lines on mute to reduce audio feedback. But as always, we welcome and encourage audience participation using the chat function. If you have technical or logistical questions, submit those to Ollie Disrochers, who will be monitoring the discussion. And we extend a huge thanks to both Ollie and to Ivan Abi-Alias from the Division of Health Systems Science at UMass Chan Medical School. They work behind the scenes to make these webinars possible. And now I'm going to introduce today's speakers. First, we'll hear from Dr. Caroline Blaum, who's a senior research scientist at NCQA. From 2012 to 2020, she was the director of the Division of Geriatrics and Palliative Care at NYU Langone Health, where she maintained an active clinical practice and an extensive translational research program supported by the NIH, the VA, PCORI, and foundations concerning disability, frailty, and patient-directed care for vulnerable populations. Before 2012, Dr. Blaum was professor and assistant dean for population health at the University of Michigan, where she led programs in Medicare Advantage, ACOs, PCMH. Dr. Blaum's policy experience includes work with the American Geriatric Society, AMAI, PCPI, and NQF. Later today, you'll also be joined with two discussants. That is Dr. Raphael Sanford-Turnett, who's an associate professor at UT Health School of Public Health and Consortium on Aging. And he is one of our current Aging Initiative MCC scholars. Also, Janice Tufte is a PCORI ambassador and is a representative from the Aging Initiative Patient Caregiver Advisory Council, and she is involved in measurement and development of measurements. So at this point, I'm going to go ahead and turn it over to Dr. Blaum.
Okay, hello everybody. I'm Caroline Blaum, as Dr. Whitson noted. I'm currently at NCQA, which is a Washington-based organization that does quality measures. So I'm sort of going to talk a little bit about quality measures today. And let's see. Okay, you could, Ivan, can you advance the slides? Okay, so here's what I'm going to talk about. I'm going to talk about what we call the quality measure ecosystem and touch a little bit on sort of traditional measurement science. Some of you may know something about this. Some of you may know nothing about this. So hopefully I'm hitting the right balance. And then I'll also talk about challenges to our traditional view of how we do quality measurement. Then I'm actually going to talk a little bit about quality measurement, where it's heading, two big places. The digital transformation, as our quality measures are all going digital, and diversity, equity, inclusion, which is very important now in measurement science. Then I'm going to talk, if I have a chance, about measures for people with complex health status, which I know is what many people in this webinar are interested in. So next slide. Okay, so traditional measurement science, but as I say, go ahead, next slide. I think many of you may have heard this in the past, but just to remind and level set, in our quality framework, when we think about quality in healthcare, there's three levels. There was a health services researcher in the 60s called Donabedian, and we still go back to how he thought about this: structure, process, and outcome. So structures are what needs to be in place for high quality care. Some of you may be, for example, familiar with patient-centered medical home. In general, the patient-centered medical home idea from NCQA, that program, is really defines standards for high quality primary care. It's not measures, it's standards. Things like staff qualifications, board certification of physicians, operational efficiency, a process to do measurement and quality improvement. These are standards. Then you get to measures. Measures, there are process measures and outcome measures. And above those little red process and outcome words, you can see examples of what might be process measures. And by most measures are process measures, and I'll get to that in a minute. But functional assessment, chronic disease management, those types of things are a process. Assess a function, you know, check the feet in diabetes. So these are processes. They're supposed to connect to outcomes, but processes are what we can measure. Medication monitoring, advanced care planning, care coordination, these are all processes. Everybody, all the payers and CMS and all the stakeholders that pay want outcome measures, but it's really hard, at least in the chronic disease world and with complex patients that you're all interested in. How do you come an outcome? An outcome is very far removed, and many different things besides a care process relate to an outcome. For example, even a simple thing like hypertension. Well, if you treat hypertension, you get fewer strokes, but this is on a population basis. Lots of things relate to strokes besides just the control of hypertension, and you can't really link in time or among a person the outcome to the process. So what outcome measures have sort of turned into in the world of quality is really utilization and cost measures. And CMS and the payers really love utilization and cost. They think if you do high quality diabetes care, there should be fewer admissions for diabetes. One could argue as to whether that's true or not, but that's where the world is at the moment. And they think that if people do high quality care of a chronic disease, the disease should cost less. Anyway, experience of care, another type of outcome that's really is very important, and I think is something that was coming, should be more common, are patient-reported outcomes. One of the patient-reported type outcome is experience of care, and that's how do they experience care? Do they experience it? Does their provider talk to them? Did they feel listened and heard and understood? Did they have communication? Did they understand their medications? These experience of care are very important outcomes, I think. And then there are also patient-reported outcomes about health and quality of life. So these are important. So next slide. Another thing to know about is all the major quality organizations that are around the country that are doing all this. we call this the quality ecosystem. So you get, and just to look at the top, here's what goes on in the quality world, right? Evidence development, guideline development, measure endorsement, and then measure use. It really shouldn't be implementation, it should be measure use. And so for evidence, you can see develop the evidence base, that comes from research. Develop the guidelines, that comes from the US Preventative Services Task Force and also from many specialty organizations. AGS, for example, has developed measures in the past and also does the research as in the Beers criteria to allow measure developers to make measures. So measures development, though, is a specific thing. We call it measurement science, and there are many entities that develop measures, from CMS, NCQA, ARC develops measures, the Joint Commission, the AMA PCPI used to develop measurement before it went out. Now the AMA does. Measure endorsement, there's been everybody wants measures to have criteria. So how do you identify the quality of the measure, the quality of the quality measure? There's an organization called NQF that does that. And finally, measure users. The measure implementers, this is a bad title. Measure implementers are actually the providers in the health systems, but people that use these measures, that take the data from measures and decide if an organization is meeting these standards, meeting accreditation, or having enough measures that they are successful at. These are the types of organizations that do that. Again, CMS, NCQA, and the Joint Commission, or as states, are some of the major ones that do that. Okay, next slide. Now this slide talks about levers of accountability, and it's based on a model from a researcher, but what I wanted to show is these three levels, because measures are at different levels. There are measures for providers and clinicians, the so-called MIPS QPP in the Medicare world. Then there are measures for plans, health plans. So that's sort of the intermediate level. And then there are actually measures sometimes for payers like states. So there are different levels of measures, and that's just what this slide is supposed to illustrate. Next slide. We always have to remember the different levels of measures, and it's actually pretty complicated. So this talks about just The world of quality can be very complicated. I know when I was in academic medicine, or even when I was doing administrative component of academic medicine, I'm like, what is going on with the measurement world? It seems so, in the Washington speak, inside the beltway. And it is just as complicated as I thought. Now that I'm more on the inside, it's very confusing. So if you think about who uses measures, where they come from, on the left, all these things are measured: health plans, states, nursing homes, traditional licensed home care, what we call Medicare certified home care, visiting nurses, home and community-based services, that's what HCBS is, hospitals, ACOs, large health systems, and clinicians. There are measures for everybody. And different entities make measures for all these things. For health plans, that's what NCQA does, the HEDIS measures, which you may have heard of. That's measures for the insurance companies or the health plans. These are mostly ambulatory care, and a lot of them target primary care. But for the states, there are actually measures for states, because CMS cares about how states deal with home and community-based services, safety net population, Medicaid, things like that. So CMS actually often makes those measures. For nursing homes, CMS often makes the measures, or they contract, and many of you heard of the RAI MDS system. For visiting nurse licensed home care, again, CMS makes measures, and there's measures, they're very highly regulated using OASIS and other measures. Home and community-based services, CMS and NCQA make measures, and there are other measure developers. Hospitals, the Joint Commission, most of you have probably, if you work in a hospital or if you're involved with academia, you all know when the Joint Commission comes to town. They accredit and make measures for hospitals, as does CMS. ACOs and large health systems, CMS, they often use HEDIS, even though HEDIS are for insurance companies. They often use MIPS for their physicians, so they have to do a whole bunch of work around measures, and it's very expensive and a big pain. And then for most clinicians, you hear about MIPS and QBP in the Medicare world, and also many insurance companies just have their own measures for physicians usually. So it's a very complicated system, and there's a lot of measures going around. Next slide. But let's just get to what makes a good measure. So switching gears a little bit. So measures, and you can read this, and I'll send these slides, will become available, but they have to be meaningful. They have to enhance health. They have to have potential for improvement and variation. If everybody's doing it already, doesn't need to be a measure. You have to have something that you can improve. An important aspect for measures, or important characteristic, is scientific soundness. So they should be based on evidence. But on the other hand, sometimes they're not, especially for the populations that we're interested in, and I'm going to talk about that. But the original idea of measurement was that it was based on its evidence-based medicine. But that rule is broken as often as it's not broken. Again, the process or structural measures have to be linked to outcomes, and they have to be accurate, reliable, and valid. And these are sort of characteristics of the measurement paradigm. Then they also have to be feasible. Can people actually do it? How expensive is it to get the data? Can it be audited so we know that people aren't cheating or gaming the measurement system? Are they specified in a precisely way? Can you get the data? So these are what you need to actually come up with a good measure. And the next slide talks about, next slide, please, that not all great ideas make great measures. And many of us have struggled for years to make good measures for complex patients, older adults, people with multiple chronic conditions. It's not very easy. For example, there's a lack of clinical evidence. So what does it mean to make measures where there really isn't evidence? We really don't know. Science can be very unsettled. Things can be moving around. Obviously, the world of dementia drugs right now, and the amyloid hypothesis says who knows what's going on. And we can't really make a measure for dementia, for Alzheimer's disease, because we are not very clear what's going on there. Risk adjustment is needed if you try to make an outcome measure, because you want to level the playing field. Sometimes something's really important, but there are small numbers, and sometimes that's a technical issue. We can't just find it because it's rare, or if the data sources are hard to find. Then there's external issues. If measures have to be understandable, they have to be actionable. Can the accountable entity actually do something about it and improve their performance? And they also have to account for differences in delivery systems and regions and things like that, patient populations. Okay, next slide. But I'm going to tell you sort of this is the classic paradigm for measure developers, and here's how you make a measure. It takes a long time. As you can see, it takes the first part of it takes 8 to 10 months, and the next part takes 6 to 8 months. And this is sort of a classic measure that you might develop. For example, control of blood pressure, if you wanted to improve the measure for control of blood pressure, or if you wanted to make a measure about, checking a foot in diabetes, or if you wanted to make a measure about a safety, not using anticholinergics in people with dementia. If you wanted to make a measure about these ideas, how do you do it? So first, on the left, you start with an evidence review, with environmental scan, what's out there, and that gets reviewed. Guidelines get reviewed, see if there's any guidelines. Prioritize measure concepts that actually, what can we actually make a measure on? What can we measure? Then you have to draft a specification, because it has to be very precise. How does a clinician or a health system or a health plan, what data they need? There has to be very precise definitions of what data or elements are needed for the measure. And then you go to a bunch of advisory panels, and you can see all these advisory panels to vet the specifications and vet the ideas and make sure advisory panels of experts agree. And many of you have been invited to be on an advisory panel, maybe for NCQA or for Yale, that's another prominent measure developer group, or for Mathematica or for CMS. There's always advisory panels, often called TEPs, technical expert panels, or EWGs, expert work groups, or MAPs, measure advisory panels. So all measure developers use panels of experts to vet their ideas. So then you do field testing. Field testing is huge. You go out and you get health plans or health systems that are willing to do this measure, and you give them the draft specifications, and you pull the data, and you see if it works, you see if it can be accurate, if they can actually do it, and what kind of early performance you're going to see on measures. So field testing is huge. It takes a while. So you get the results back, and once you get the results back, we put it out to public comment. And any of you who have been involved with AGS in our AGS committees, we often reach out and say, AGS wants to comment on this measure, or wants to comment on what NCQA is doing or CMS is doing. So this all goes out to public comment. Then we all review the results of the public comment. Then we revise the specifications. We go back to the expert panels and say, here where they are. And when we get through all of that, you finally have measures. So it takes a long time. Okay, next slide. One big thing that you should remember about measures is that data collection methods are important. You have to have, and there are 4 real ways that we get data for measures. One way is administrative, so that's usually claims, or it's usually claims. And then sometimes it's hybrid. Hybrid means we use claims, but somebody has to review charts. Sometimes measures come from surveys. There's something called the Health Outcome Survey, which is important. And sometimes measures are digital, and that's what's going on. That's what's going to be happening now. And you can see here that there are, for the denominator of a measure, because every measure has to have an eligible population, the entire eligible population can fit if you use administrative measures. But in a hybrid, you have to take a sample. In a survey, you take a sample. But if you do a digital measure, which is usually based on an EHR, you can take the entire sample. And so, and this just shows, this slide just demonstrates the pros and cons of each type of measure. But I'm going to talk about now that the ECDS, or measures that use the electronic clinical record, and other clinical data are what are coming to the plan. The con of that, if you look at the bottom right, for ECDS measures, is some people can't do it. Yes, some health plans and health systems can't really do it, even though the pro is that they capture clinical data better. Okay, next slide. So I wanted to say about all this classical paradigm has challenges. So that's what we've been doing for 15 to 20 years, but we now know that, the days of the easy measures are over. Like everybody should check a blood pressure, and everybody should do a A1C, and everybody should get a flu shot. So now we're realizing that that doesn't really describe quality the way we want to, and that there are a lot of challenges anyway. So let's go to the next slide. And so here's some of the problems with what we're doing now in quality. First of all, as I say, this is started in the early 2000s. They were created for different purposes. There wasn't the digital and EHR capabilities that we currently have. So the measurement system now is very expensive. All this money, 20 billions or whatever, is going to this sort of quality measure industrial complex and not to patient care. It's fragmented. There's all kinds of different measures, different payers want different measures, and it can be very confusing. And it's expensive for practices and health systems and plans. The data can be variable. Some health systems are, very good at their data. Some practices, they don't have the resources to do it. And so it can be very unclear as to whether the data is any good. The measures now are very retrospective. So usually it's a year and a half, once you get your results of your performance. So how do you go back and fix something that, you're only knowing a year and a half ago what you did? And some of them even worse than that. Some of the survey measures are like 2 years, 2.5 years. So they're retrospective. You can't really act on it. And also, what matters? And that's where we sit, those of us who care about people with multiple chronic conditions and complex care. And we're not measuring what matters to people. So we're measuring what we can, but not necessarily what matters. Next slide. And so for those of us, I'm talking to the choir now. For complex people, they get care all over the place. How does measurement capture the coordination? Their care is fragmented, burdensome. It can be dangerous. Even if you follow if you extrapolate measures for younger people to older people, you can get a big mess and poor outcomes. So we have a huge problem in measurement of complex patients. Next slide. So, and again, the evidence-based paradigm, all of measurement was based on the evidence-based paradigm, and it certainly falls apart in people with multiple chronic condition and in complex patients anywhere. We think as geriatricians and palliative care physicians who are our complex patients that we think about, but really children can be complex, people with intellectual and developmental disabilities, people with severe mental illness, people who have severe socioeconomic problems. So it's not just older folks that are complex, but regardless, we have no evidence. This is an evidence-free zone, right? Major trials are disease specific. They exclude people with multimorbidity or frailty. They don't talk about adverse events often. So we sort of need new and different evidence, and we have to think about trade-offs, uncertainty, trajectories. So it's very hard to measure quality of care in the populations that need the highest quality of care. Next slide. So, as I said, the current measures are often not relevant. Sometimes they get at important things, but it's really checking a box. Did you assess this? Did you assess that? Did you assess this? And they don't foster integration of personal medical care. But we're trying to come up with some future measures that address what matters most to the patient and help improve communication and are flexible and usable. So that's the challenge. Next slide. So, and I will say CMS is obviously the elephant in the room. They care a lot about quality measurement. They have huge sections of CMS devoted to this. And they have articulated a meaningful measure idea 2.0 that actually shows that they actually do understand the problems with current measurement science and what we're doing. They want to move towards measures that really are the highest value and impact key quality domains. They want to align measures so people don't have to do all kinds of different measures from all kinds of different plans. They want to prioritize outcome, but mostly patient-reported measures, and I think that's very important. They want to go digital by 2025, although I think they've changed that, and I think they're talking about 2030. But they want measures to be digital, and they want measures, at least for the next 2 years, that reflect social and economic determinants. Okay, next slide. So the last thing I want to do, and I think I have time to go through this. I want to use a very common measure that you would think, blood pressure. Everybody knows blood pressure control is important. It's important for a younger middle-aged person, and even in our complex patients, most of our complex patients have high blood pressure, and it's hard to deal with it. It can fluctuate. They can have reactions to medicines. It can be so blood pressure is sort of a hard thing, but you might think that, well, it's not very complicated. Blood pressure is measured, we treat it. there should be a measure for blood pressure. And I want to use this blood pressure control and diabetes to show even in what should be a very straightforward measure, it's a mess. So measurement is very hard. It's hard to do this. So I don't know if people can see this, so you have to squint a little bit, but I want you to look at this is a measure specification. And it's an example of blood pressure control and diabetes. It's an old measure. It's probably been around for 15 years. And so you can see if you look down, if you squint a little bit and look down at the description, it says the people in the measure, the percentage of patients 18 to 75 years of age with diabetes whose blood pressure was under 140 to 90 during the measurement period. Well, look right there, you can see something from our purposes. It stops at 75. So even though 40% of people with diabetes in Medicare are over 75, this measure stops at 75. And it's not individualized in any way. It just says 140 over 90. And the next thing, it does go by guidelines, and you can see there still are guidelines, and that's what the guidelines say. You can see that's an area. And then if you go over to the right, look at the thing that's called exclusions. Squint a little bit and see exclusions. So measures have exclusions, and people are tossed out of the measure. So here it makes sense. People in hospice are tossed out. People 65 and older in a nursing home are tossed out. People 65 and older who have frailty or advanced illness are tossed out. And I'm going to talk about that in a minute. People receiving palliative care are tossed out, and people receiving end-stage mental disease are tossed out. Now, that's good. The fact that these people, because blood pressure in those people should be individualized, right? That should relate to how it relates to those people. So all those people, you can't just say 140 over 90 in a discussion. All of those types of patients, it should be individualized how we treat them. So it's good that they're tossed out, but I'm just pointing that out, that they're not part of the measures. Okay, next slide. So even for blood pressure, let's see what else is a problem. Another big complicated thing, and I'm not going through the slide, but for a measurement, you have to define who's the eligible population. So you have to figure, and that means how long have they been in the plan, or how long have they been in the practice? And you can just see how we go through all kinds of ramifications. Well, they have to have a diabetes diagnosis in the prior year, but it has to stop 6 months later, so you have time to work on. So you can imagine that defining the eligible population, especially if you're thinking about a practice, it can be very confusing. Next slide. And here I'm going to talk, I talked about exclusions. So the denominator of a measure is the eligible population minus exclusions. And this is what I talked about before. These are the ones people who are not in this blood pressure measure for blood pressure and diabetes. Next slide. So again, reminding of every measure has an eligible population, a denominator, and a numerator. So that's, and most measures are a rate, right? What's the percentage of people who meet the numerator criteria over the eligible population? So here the numerator, the patients whose most recent blood pressure is controlled during the period. And so the other things that I'm just going to show are current blood pressure measure in people with diabetes, a bread and butter measure that's been around forever. It's a hybrid measure. They have to look in the charts. We're now turning it digital, so we're going to start looking in the EHRs. But right now, somebody has to go in the chart and check that all these diabetes people have their blood pressure under 140 over 90. It's only the latest blood pressure in the year. So, you know, if they come in and they have a bad blood pressure because they're sick or something else, that's what counts. And then how do we define hypertension? Do they have to have a claim with this or a claim with that? How many times does it have to show up? How do you know the person really has high blood pressure or doesn't? So the future state of this measure, as I said, this bread and butter measure, the future state is it's about to become digital. We're going to use the EHR, and then there's a whole discussion about how do they have to have a medicine, or they have to have one diagnosis, DX is diagnosis, two diagnosis, about home blood pressures. We're doing a lot of virtual care. So how about people that have a lot of blood pressure? Should we average them? Is 140 over 90 appropriate for all? What should we do about excluded groups and people over 75? And of course, how do we deal with disparities? So you can see the bread and butter straightforward measure is really complicated. So think how complicated a measure for complex patients would be. Next slide. So I wanted to spend a little time talking about digitalization and then diversity, equity, and inclusion, because these are big things that are coming down the pike. I see, I'm supposed to stop at what, about 8 minutes, maybe 10 minutes. Anyway, let me just, but I do want to clue you into this, but I might go pretty quickly. Next slide. So this slide is adapted from CMS, and measures now, as I said, people review and chart. We call it paper, but it's, Excel spreadsheets, but they're checking things off. So now there's something called electronic clinical quality measures, which some of you may have heard of. Those use data from EHRs. And then we're actually moving to digital quality measures, which sort of put EHR data with claims, with other patient experience surveys, and sort of mushes it all together and has interoperability of these different types of data. This is a bit of a programming and measurement challenge. Okay, next slide, but that's where we're going. And people think this digital measure roadmap moving, it would make things better, will make quality measures better. They think we'll get better data, better insight, or patient-specific care, and it will help value-based payment, and they think it will also decrease measurement burden. So I don't know if that's true, but that's what people who are involved in this think. That's certainly what CMS thinks. So specifications for measures are now getting written, not in words, but in programs, digital quality measure format. We need programmers to write these measures now. They're using electronic clinical data for HEDIS, and MIPS is already going that way. And there's something called FHIR CQL standards. So those of you who are informaticists can sort of look that up, but there are national standards that CMS and the Office of the ONC, which I can't remember, Office of National, I can't remember what that means, but that has to do with digitalization. The government really cares about this and cares that the standards talk to each other. And this is all going on nationally. Next slide. So, and for NCQA, you guys just click through it. So NCQA already has a bunch of, as you will see, these are sort of, again, bread and butter population-based measures that are going to be done in electronic clinical data. A lot of it's immunization, depression screening, social needs and follow-up, which is actually done in digital, which is sort of amazing, breast cancer screening. Okay, next slide. So for these ECDS measures, where there's a goal, again, CMS was saying 2025, but I think they have expanded that date because it's going to take people a long time to do it. Organizations have different starting points, different rates of progression, but CMS really wants, and so does NCQA and other measure developers, want the early adopters to start doing this so that we can understand how it works. And next slide. Okay, and the last thing before I get to measures for complex patients for my last 5 minutes, I want to talk about building a path forward. And NCQA has done a lot of work in diversity, equity, inclusion, as have other measure developers, based on the idea that quality care is equitable care. This started in 2020 in earnest. And in 2021, you'll see that what we're doing is taking regular HEDIS measures like diabetes control or medication safety or other ones that I'm going to talk about, and stratify for socioeconomic status and race and ethnicity to see how that works. And there's a lot of issues about the methodology for the stratification. So in 2022, we now have a social screening and referral measure that I'm going to talk about in a second. And for 2023, we're developing a measure for social connection. We're analyzing the social screening measure, and we're working on social connection, and we're also working on sexual orientation and gender identity stratification, or SOGI stratification. So next slide. And these are just the candidate measures for stratification. So as you can see, I think diabetes is right up there. I'm not really sure, but next slide, breast cancer screening and things where we know there are disparities. But I wanted to talk very briefly about a brand new measure that we're very proud of, social needs screening and intervention. And this is actually digitalized. And for those of you who are informaticists, just send me an email and I can explain how we managed to do that. But what this is the percentage of members in a plan who were screened for unmet food, housing, or transportation needs using a validated instrument. And if they were positive, they got an intervention. And this measure now is in first-year testing, and health plans around the country are doing it. And some health systems around the country are also starting to do this because, this measure was developed very well. Next slide. Yes, Office of the National Coordinator. Thanks, Janice. I just couldn't remember that. Okay, now here's a social connection that we're working on right now. And this is a sort of loneliness. We know that's can be a big problem in older adults and in other people. So social connection is an umbrella term that encompasses structural, functional, and quality aspects of how individuals connect to each other. And it has 3 domains: social isolation, loneliness, and inadequate social support. So we're working right now to try to develop a measure capturing this concept. It's very hard. It'll be a digital measure, but just so you know, this is a very interesting measure. And for those of us interested in complex patients, this and the previous measure are probably very important in terms of social determinants of health and things that really influence the health of the people that we're caring for. So next slide. Okay, so I want to just take a few minutes to talk about measures for complex patients, because that's sort of what we all care about. But I think I probably convinced you that it's not even easy to do a measure for, like blood pressure that affects middle-aged people, let alone measures for complex patients. So nonetheless, we have tried, NCQA and other measure developers have tried over the years. So the next slide. Okay, and so here's sort of what measures that we have that are for people with complex health status. Some of them are actually very old and not very sophisticated. They're assessment measures, and some of them are actually very good and high quality. So one measure, SNPs, so you can see, let me just show you the categories that they're in. SNPs is special need plans, so that's that, and also what matters. I sort of stuck them together because they actually do go together in a way. Another thing that NCQA has really pioneered, and they're very good, is medication measures. We have a lot of measures for safety. Many people from AGS were involved. They're often connected to the BEERS criteria in NCQA for AGS, and a lot of the people that have been on our expert panels are geriatricians and people interested in complex care. So we have use of high-risk medications in the elderly, potentially harmful drug disease interactions in older adults, med reconciliation post-discharge, hypoglycemia leading to ED visits, and deprescribing of benzodiazepines in older adults. And we have a good portfolio on that, and people have worked very hard with a lot of outside help. Mentation, we have a lot of measures about depression screening and follow-up, and mental illness, and these are good measures. They relate to older adults as well as others, but you might notice that there are no dementia measures. And there's a lot of reasons for that, partly because it's not clear what to do with dementia except for support the caregiver. So a lot of the measures are really social and sort of structural. There should be a structure to support that caregiver. And of course, the caregiver is not the patient. So we actually don't have much in many measures for dementia. That's a big gap. Then there's some measures for older people that come from something called the Health Outcomes Survey. And I actually remember when that was started around the year 2000. It's an old survey. It no longer meets our best understanding of how you do survey research. But a lot of measures that are important for older adults are actually in this survey. Fall risk management is in the survey, physical activity in older adults, urinary incontinence, improving or maintaining mental health and physical health are all from the survey. And the survey, as far as we know, can't really be digitalized. So it's very unclear what to do with some of these measures, even though they're important. And finally, outcomes and utilization measures. Again, these are ones that CMS really likes, and you've heard of many times: all-cause readmission, hospitalization after discharge from a skilled nursing facility, follow-up from after ED, a visit for multiple chronic conditions, transitions of care. So these are the types of measures that we have. So next slide. Before I get anywhere, I wanted to make you aware of two things that are super important. One is the measurement of frailty, advanced illness, and multiple chronic conditions. There's something called value sets. And if you look at some of you who do a lot of work in informatics or work with claims or work with EHR research, you may have heard of all this stuff. There's a National Library of Medicine Value Set Authority Center. And this slide, I think, is sort of important to understand, because in the digital world, everything is value sets, and really they're just big long lists of codes that describe an entity. For example, there's a value set for frailty. In fact, there are 4 value sets for frailty that you put them together, and there's a criteria of who's frail. You can see on the left, I have all these value sets. There's value sets for outpatient visits and advanced illness and multiple chronic conditions. We have a multiple chronic conditions value set, which I'm going to get to. So it's something to sort of understand if you're going to do quality work or work with EHRs. So these frailty and multiple chronic condition value sets were developed in conjunction with national efforts. So there's national people working on this, and maybe some of you on the call are also working with this. They involve there's lots of value sets. The frailty and advanced illness is actually an exclusion. People that meet these criteria that we consider frailty or advanced illness, they're thrown out at 12 HEDIS measures. And it's appropriate, and they probably should have been. But just to understand how this works, this is in the weeds, and many patients that we take care of actually are not in the measures. There are lots of codes for all of these. ICD-9, those of you into informatics know about link codes and SNOMED. These are machine readable diagnoses. Then again, for frailty and advanced illness and multiple chronic conditions, there are lots of lines of code. Let me just show you the multiple chronic conditions value set, and then I'm going to sort of be about done. Next slide. So this is what is the multiple chronic condition value set that NCQA has been using. And again, this is in conjunction, I think, maybe with ARC, and there's maybe a group in CMS that's trying to refine this. I'm not sure when it's due to be redefined, but we have a measure, ED follow-up for people with multiple chronic conditions. And this is, I believe, the only measure in HEDIS where this multiple chronic condition value set is used. And here's what's in it. You can see COPD and asthma, there's a big value set. Alzheimer's disease related disorders has a big value set. Chronic kidney disease, depression, heart failure, AMI, atrial fib, stroke, and transient. These value sets collect all the ICD-10 link codes and SNOMED codes that describe these conditions. That's what they are. And this is important at some point to sort of understand. If you ever invite me back, I can go into more detail about these things, because this is how measures are going to be built for complex patients. Notice diabetes isn't in there. There's many things you can notice that's not in there, but just saying. Next slide. I think I want to stop soon. I want to see if there's anything else I wanted to show you. There's an old measure called care of older adults. The only reason I want to bring this one up, it's important, is because this measure is actually in something called STARS. For any of you who are involved in health policy, CMS STARS indicators are the measures that CMS thinks are very important for older adults, and they're actually used to pay Medicare managed care plans or Medicare Advantage plans. So this STARS, this COA measure, is actually an old measure that's been around for a long time, but it's actually used to pay the plans. They have to get a good result on it. It has 3 indicators: pain assessment, functional status assessment, and medication review. So that's an important measure. Next slide. We're actually retiring it. And the one thing I want to talk about with care for older adults, the pain assessment indicator was just this: assess pain once a year. That was it. It's an old measure. We didn't know how to do it very well. So we're actually retiring that, and we're going to go with some more up-to-date ideas about pain, like multidimensional assessment, acute versus chronic follow-up, etc. Okay, so I think, let me see if there's one more that I want to do. No, I'm going to skip that one. I think I want to stop now because, you know, I could be talking for 3 hours on this stuff. Next slide. Let's see if there's anything I want to end with. Ivan, could you just go to the title slide for patient priority? Keep going. Keep going. I want. Keep going. Keep going. A lot of I could talk about this for hours, as you can tell here. Now I want to just end on this. The challenge for us is to really measure what matters, and to try to figure out how to, and to me that a lot of that is to figure out from the patient, what does the patient care about and what matters to the patient. So perhaps at some time I can come back and talk about that because we are lurching towards, or sort of slowly, maybe slowly crawling towards getting measures that matter to people. And NCQA and I have been working on that for some time. So sometime I would like to talk about that. But this was supposed to be just sort of behind the curtain and what measurement looks like and sort of the messiness of it. So I want to stop now and let our commentators talk. And sorry it took a while, but there's a lot to say in this world. Okay, so I'll be finished now.
All right, thank you, Caroline. That was just a tour de force, really incredible information. So I'm going to invite Janice and Raphael, and I don't know if the two of you had pre-decided one of you wants to go first.
Janice can go first.
Okay. Janice, we can't hear you if you're.
Oh, I thought Raphael was going first. I'm sorry. Hi, I'm Janice Tufte, and I'm an individual who serves on the Aging Initiative APCAC, which is the council. And I am involved with measurement. I'm actually more involved with the endorsement of measurement with NQF. And so as a patient who's involved with measurement, I really appreciated this overview, and it's one of the most comprehensive and concise overviews I've seen of quality measurement. And I'm very excited as an older adult to see that you're looking at social drivers, and you're going to be looking at loneliness as well as updating the pain assessment. So I do believe that there's been myths regarding older adults and pain. And for many years, people think, oh, you know, they don't feel pain. It's actually, I've heard this. And so this is really important. That's going to be updated. And as I mentioned, the social drivers and loneliness, I believe we have, for sure, we have over 30% of Medicare patients, I believe, or recipients are living alone. And so this is a, you know, there's a difference between living alone and loneliness. So it'll be interesting what you come out with. And I just wanted to say I appreciate it. And you could always come to our APCAC if you'd like some more information on upcoming measures, anybody. Thank you.
Thank you.
Thanks,
And
Jen.
Raphael.
So it's a pleasure to share with Caroline, and I can't stop saying that Caroline showed me patient priorities care, and that significant change my career moving forward. Coming to the multiple chronic conditions scholars program, my interest has been how cognitive impairment actually impacts the whole complexity of multiple chronic conditions. And recently at a meeting with Carolyn and other people, we talked about goal attainment scaling and how that could be a possibility on how to actually get more into what Carolyn was mentioned about patient-reported outcomes, what's important to them, what really moves them, and what really makes a difference. So I would actually, given that Caroline was part of the initial group for patient priorities care and actually getting into what matters most from a structured way. I don't know if you've have the time to think about this and discuss this. I imagine you have. But when we think about what matters most within the age-friendly framework, and even when we look at patients with multiple chronic conditions and what matters most to them, even though we have a structured method to get to what's important to them and what matters most to them, we are still getting a lot of pushback from reviewers when we submit grants on, are the measures that you are using really measures of what matters most to patients? So we use the Collaborate and we use the treatment burden questionnaire to get and see if we can decrease burden and if we can make patients and care partners feel a little better in terms of what they're doing and what they're accomplishing as part of the care that they receive. But we still get a lot of pushback. So I'm wondering if Carolyn can talk a little bit about the what matters most piece and how to get a little bit into measurement that reviewers and the public in general might feel a little more comfortable when we're talking about actually measuring if we're capturing what matters most to those complex patients.
Well, thanks for that, Raphael. I don't know. I would have to ask Ivan and Heather if they want me to do 5 minutes on on person-centered outcome measures. I sort of skipped that because I thought there might be questions. But what do you think, Heather and Ivan? Do you want me to do that? It's the last few slides that I skipped.
Sure. I think speaking on that, or your preference, if you right to just riff and answer the question, or go back to the slides.
I think the slides. I can do I
Okay.
can probably do a couple slides in a few minutes and still have a chance for questions. I can
Great.
go
And-
over it. Yeah.
And in the meantime, we have one question in the chat for you after that, and I'll just encourage other people if they have questions to
Okay.
put them in the chat. All right. Take it away.
So Ivan, can you go? Yep, there we are. So this is what Raphael was talking about, folks. Person-driven outcome measures are what matters most. As I talked about all the problems with measures for complex patients, you really sort of have to get down to the true north, right? We don't have very much evidence. We aren't clear what to do. And it really comes down to people to working with patients to figure out what they want out of their health care. What do they want? That's one of the most important parameters of quality. So person-driven outcomes are outcomes that we think of identified by an individual or caregiver if the person is working with their care partner. These are important outcomes that can be used for care planning and for quality measurement. So next slide. So NCQ has been working on this, on how to measure what matters for about 9 years. And again, we have a measure now. We have 3 measures, person-driven outcome measures they really are measures of the future. They're going to be digitalized. They work along with clinical care. They're in the moment. They're not retrospective. And this is a diagram that shows how they work. Clinically, the clinician elicits what's important with the person. Then we figure out a structured way to measure it, because if you're going to have a measure, you need a structure. So how do we actually structure the person's personal goal? So we take 2 ways of doing that, either one of the NIH PROM instruments or something called goal attainment scaling. So we can structure this. Then clinically, there's an action step, clinical decision making, a care plan that addresses what's important to the person so that they can try to achieve it. Then clinically, there's a reassessment, and we measure if it was reassessed. And then we have an outcome measure, a patient-reported outcome measure. Did they actually improve or achieve their goal? So next slide. An example of what matters most to many of our older adults, and you would know this if you talk to your patients, they want to stay out of the hospital. They may want to be able to make their appointments. They want to go to the church. They want to do things. They might want to involve in society, go to arts and craft classes, walk many functional things, walk around the block, etc. Next slide. And so one of the ways to track these personal measures, and we teach clinicians to match a PROM instrument with the personal goal. And this is an example of that. If a participant's goal is to relieve the back pain so they can do their woodworking, you might pick a PROM about pain interference. If the person really wants to continue with a medication program, with their treatment program, you might pick self-efficacy to manage medications. If they want to regain their strength so they can go fishing, you might pick a mobility PROM. Next slide. There's another type of instrument that we can use to track, which is called goal attainment scaling. This has actually been used in dementia patients by Lee Jennings at Oklahoma and David Rubin at UCLA. And this is an old type of scaling where you take the personal goal. A lot of people like this because you take the personal goal and you figure out where they are now, why they're not meeting it, what their goal could be, and how they could do a little bit better. And it sort of preserves the personal goal. And this is just a 5-point scale. The person where they are now is -1. Like this is an individual with multiple chronic conditions who wants to walk their dog. That's important to them. So right now they're not walking their dog. So what your goal as a healthcare provider is try to figure out what interventions you can do so that person can walk their dog. And so then they would achieve their goal and the measure would be met. Okay, next slide. So here are the 3 measures, and NCQA is actually testing them. We've already tested them a lot, but here are the 3 measures. Assessment of the person-driven outcome, document it in one of these ways and have it document a plan, then follow up, and then did the person achieve or make achieve or make progress. And we can stop here, but I'll just say that NCQA has tested this. It's been tested in many types of providers. It's been tested in 1,300 patients. It's been tested in lots of providers can do it. It's been tested in different 13 types of delivery systems, both geriatric care, long-term geriatric care, serious illness, and long-term services and supports. So it was actually tested in a research project. I were trying to get the papers out. But now, even the testing was so encouraging that, supported by the John A. Hartford Foundation, the SCAN Foundation, we actually now have learning collaboratives. And learning collaboratives are what NCQA does when we're very serious. We are specifying this measure. We're going to be digitalizing this measure. You know, we are working with LTSS plans, geriatric practices, also with behavioral health groups. We have, it's, you know, really tens of thousands of patients, you know, thousands of providers. And we're going to try to stand up this measure. Remember the measure development process I showed you? We're in the testing phase where we're trying to test our specifications and really turn this into a measure that will be suitable for both HEDIS and NQF. This is a tough measure. It'll take 2 to 3 years to do that. But anyway, so that's what Raphael was talking about. And this is, I think, part of the future for complex patients. This is the type of thing that the type of measure that we need. Not the only one, but an important one. So thanks for letting me do that. This is dear to my heart.
Yeah, absolutely. I'm glad we got to that too. I think there's praise in the chat about the PCOM. And also I'll take, I think we might have time for about 2 of the questions that have come in the chat. One of them is just asking, you had mentioned that the health outcome survey is very important, but it can't be digitized. And there was a question from Sarah Green about, do you know if there's any work afoot by its administrators or creators to overcome that impediment and make it potentially digitizable, since that does seem like a gap? Oh, you're on mute.
Now, this survey is so old-fashioned, they actually mail a 20-page document to people and people fill it off and mail it back. This survey is important to CMS, and quite frankly, it's such an institution that it's one of those things, like, it's really hard to change. There are several STARS measures, I think 5 STARS measures on it. So, and again, the plans are organized to sort of do this, and CMS is organized to do this, and CMS, I think, would really love to update it, but it's just one of those things in the world of in life. It's just really hard to change. So I don't know. CMS thinks about it a lot. The CMS people that do it are very knowledgeable, but you know, they're constrained. And so when I said it's not clear how to digitalize it, I mean, digitalize it in the way that we digitalize other types of measures. It could certainly be digitalized in a different type of way. So anyway, there's a lot of people thinking about it, and a lot of, you know, NCQA, CMS, RAND, you know, a bunch of different consulting groups. A lot of people are thinking about it, but it's sort of like moving the Titanic.
Understood. So I think we might have time for this one last question, which is, can you comment on how person-reported outcome measures differ to or relate to advanced care planning, and whether there's a crosswire between ACP and person?
Yeah, that's something that I'm very interested in. And even when we started doing, you know, patient priorities care, so the clinical piece of it, that came up a lot. To me, it's upstream. You know, to me, people with, and there are also many people with complex health status that are not dying, right? People that are
Sure.
have serious mental illness and other things. So it seems like there are many people where the goals, this is not advanced care goals, it's current care goals. It's what do you want all the care that you're getting to allow you to do? That's really what it's about. And so it's sort of upstream from advanced care planning. It's really very different. It's here's what's going on now. How can we organize it to get you to achieve what you want to achieve? It's just a sort of a little bit of a different framework.
Absolutely. All right. Well, thank you. We are at the hour, and I think you said it well. We could talk about this for 3 hours. We really appreciate you spending your time with us and sharing your expertise. And it's been said in the chat, but a version of these slides and the recording will be available in about 2 days on the Aging Initiative website. So thank you so much. Thank you also to our discussants, Raphael and Janice. Thank you.
Yes, thank you very much. Appreciate it.
Thanks, everyone. Bye-bye.
Bye-bye.